Good afternoon, everybody. How are you all doing?
Recording in progress.
Yeah. Hello, everybody. Hello, Sakshi. How was the exam for you all? Just give me a minute, okay? I'll just be ready. Okay. Hello, everyone. And I hope, कैसा था exam कैसा था? Hello, Rustam, Rehnuma. How was everything for you all? How was the pediatrics exam and how did you do with radio? Did you manage well? कैसा चल रहा है? I'll not take much time here in this discussion. Good afternoon, Alam. I'll not take much time. I'll just do it very brief. Just we'll look at the explanation part. I'm trying to see that we complete this in as short as 1.5 hours max that we would want to do. Uh, nice. Let's hope. Fine. Arafat, could you message me? Okay, let me just take the thing. I'll just work on this. Okay. Let's get started. I don't want to do lot of time with this. This is a short discussion. I just want to complete it in 1 hour so that you get time to study for tomorrow. Radio, anyways, I'm doing a YouTube session where you will do the entire revision also, fast track. And if you need anything more on that, we'll work on it. Let's get started with our topic. Okay. The first one here. Okay. I've bolded the answers and just try to think with me what is what. A 25-year-old male who got involved in road rage presented to the emergency with stab injury to his chest on the left side. A supine radiograph is obtained from the patient, and what is the probable diagnosis? So, if you look at this image carefully, you are seeing that the trachea, if you see, I asked you to look at the trachea first. So, whenever you are seeing that the trachea is being shifted to the opposite side, right? So, there is some collection here, right? So, there is a volume gain here. And you see a opacity in this region. So, the injury is on the left side, right? And the opacity is on the left side. So when there is an opacity, that means there is fluid there. If it was pleural effusion, it would not be due to a stab injury. But if it is hemothorax, it can occur due to road traffic accidents or stab injuries. So because it is a road traffic accident or a stab injuries that are there, these can lead to hemothorax. And being a supine patient, this is all haziness gone all through the chest wall. Okay, so the entire chest wall on this left hemithorax is appearing opaque. So this is hemithorax. If it was lung collapse, the trachea would have shifted to same side. The heart, the trachea would have shifted to same side if it was collapse. So that is the reason it is not collapse. If it is hemidiaphragm rupture, you see the hemidiaphragm much higher above, right? So that would be hemidiaphragm rupture. And pleural effusion, obviously, if it was pleural effusion, it would not be associated with stab injuries and stuff. It can be due to masses or it can be due to tuberculosis, but not due to a stab injury. So better answer here is what? Hemothorax. Now let's come to the next one. Hyperdense MCA sign. Hyperdense MCA sign, this is a sign of acute infarct. I taught you this in your neuroradiology classes. I told you that if you look at the brain parenchyma, infarct is a wedge-shaped area of hypodensity that you have, okay, in the area of arterial territory. And this is a black area. Infarcts are hypodense on CT, black on CT scan. But one of the early signs of acute infarct is the middle cerebral artery, which is going towards it, becoming hyperdense. So it is becoming more dense because of the thrombus inside. So hyperdense MCA sign is a sign of acute infarct. What is a sign that you see in tension pneumocephalus? Anybody? Do you remember the sign that you see in tension pneumocephalus? Tension pneumocephalus. This is Mount Fuji sign. Mount Fuji sign. Any signs that you remember, any radiological signs that you remember in progressive supranuclear palsy, guys? Do you remember any signs of PSP, progressive supranuclear palsy in radiology? Do you remember anything about progressive supranuclear palsy? Mount Fuji sign, I have given you the image in your neuroradiology classes also, right? Mount Fuji is been asked this exam and in INSET exam, and I have given you that classic image where the air comes in front of the frontal lobes, right? I have taught you that in your neuroradiology classes. You see that air in front of the frontal lobe, black color air there. Right? That is how you have your Mount Fuji sign. That is tension pneumocephalus. I've given you those images. So very good, Akshar. You're talking about hummingbird sign. Hummingbird sign, also called as penguin sign. Penguin sign. This is seen on sagittal MRI. And you also have a Mickey Mouse appearance on axial MRI. So these are seen with progressive supranuclear palsy. And what is the MRI finding of Wilson's disease? What is the radiological sign seen with Wilson's disease? You have a face of giant panda. Face of giant panda sign. Right? So these are the different signs that you see. So hyperdense MCA, there's a thrombus that you see in the middle cerebral artery. Hyperdense MCA sign is one of the earliest findings of acute infarction. Next. What did you answer this? A middle-aged male presents with pain in the thigh and the following radiograph is obtained. So when you look at the radiograph, you are seeing that there is a patient with pain in the thigh and in the femur. You can see this is the patella, this is the femur, this is the tibia that you are having. So within the femur, you can see a center dense area, this dead dense zone in the center. This is called as sequestrum. Sequestrum. And can you see all this periosteal newborn formation? The thickening, the cortical thickening that you're seeing, the periosteal thickening that you're seeing, this periosteal newborn formation is called as involucrum. So sequestrum and involucrum. So this is chronic osteomyelitis, right? So this is about chronic osteomyelitis. Now, true about CT scan. CT scan, the Hounsfield unit of CT, the reference value, the Hounsfield unit is for fluid or water, and that is 0. This is the correct statement. They asked you the true statement. This is the correct statement. Remember, investigation of choice for acute cholecystitis, ultrasound, not CT scan. And if you remember the CT head, CT abdomen, I discussed in the classes also. When you look at the head area, right, the chest and the abdomen, the head will have small area. So this is having radiation dose of about 2 millisievert. Chest and abdomen, if you see, the abdomen is big area. So compared to chest has around 8 and this has around 10. Okay, 268. Okay, so around chest XCT, chest is around 6 millisievert and CT abdomen is around 8 millisievert. And I told you that the surface area is less. So you'll have less slices going through the head and more slices going through the abdomen. So the obviously radiation dose of the abdomen will be more, not less. So he said CT head is more. This is false statement, right? This is false statement. Unfiltered X-ray beam is used during CT scan procedure. This is also a false statement. Remember, X-ray beam which is unfiltered will have high energy and low energy X-rays. High energy and low energy. Low energy X-rays, they only give radiation, exposure, radiation. No, they do not penetrate. And we need to remove these low energy X-rays. For this, we use filters. Filters remove low energy X-rays. Right? Filters remove low energy. Filters in X-ray tube, they are made up of aluminium to remove the low energy X-rays. So we don't use unfiltered beam, we use filtered beam so that you don't have this unnecessary radiation which does not penetrate the patient, only give radiation to the patient. We don't want that. We want a filtered X-ray beam. So that is also a false statement. So the correct statement is the CT unit of Hounsfield unit of water or CSF is 0. It's a simple one, but it will be asked. Can I ask you what was the CT scan unit of acute bleed? Can you tell me what is the Hounsfield unit of acute bleed? Anybody? Anybody revised this acute bleed Hounsfield unit? Plus 62 plus 70. Plus 62 plus 70. Do you remember of calcification? Anybody can with calcify fast? Calcification. Do you remember what is the Hounsfield unit of calcification? Around 200 to 250. Right? So around 200 to 250. What about fat? Can I ask you about fat? Fat, what is the fat Hounsfield unit? Around minus 50 to minus 100. And air is about minus 1000 Hounsfield unit. Whereas fluid or water, this is the standard reference. This is about 0 ounce per unit. This is the reference value or standard value that we use in CT scan. So this was tested. This is simple only, right? Let's come to the next one. Contrast agent that can be given in chronic renal failure. Now, remember, iohexol is iodinated contrast, will have risk of contrast-induced nephropathy, right? So, contrast-induced nephropathy is increase in serum creatinine, right, by more than 0.5 milligram per deciliter or more than 25% from baseline. Gadolinium is known to produce NSF, nephrogenic systemic fibrosis. What is CIN? Contrast-induced nephropathy. Contrast-induced nephropathy. What is NSF? Nephrogenic systemic fibrosis. Gadolinium is known to produce nephrogenic systemic fibrosis. Gastrographene is nothing but diatrizoate salt. So this is again ionic monomer, high osmolar contrast agent. And high osmolality means more nephrotoxicity, more nephrotoxic. So we can't use any of this. But sonoview, the word sono means ultrasound contrast. This is ultrasound contrast. An ultrasound contrast has gas bubbles, microbubbles of gases. Microbubbles of gases. And gases, the commonly used gas is sulfur hexafluoride. And this is released by lungs, not by the kidney. So we use sonoview in chronic renal failure. I taught you this in your classes also. Pre-contrast RFT, if you look at the notes, pre-contrast RFT is not needed for ultrasound contrast agent. We don't need to do pre-contrast RFT. We don't need to measure serum creatinine levels and stuff before doing the ultrasound contrast. Okay, ultrasound contrast are safe in kidney pathologies. Next thing. Did you get this right? Identify the mark structure in the given CT scan. So in the given CT scan, you saw that the middle turbinate is pneumatized. So pneumatized middle turbinate. Pneumatized middle turbinate. Is what is called as concha bullosa. Concha bullosa. So pneumatized middle turbinate. You can identify the turbinates, right? So this is the inferior turbinate. This is the middle turbinate, right? So the middle turbinate is having air-filled cavity. So it's air-filled, right? It's pneumatized middle turbinate. That is concha bullosa. Concha bullosa. You study in your ENT classes. The pneumatized middle turbinate is called as concha bullosa. And what are these Haller cells? Can you tell me what is Haller cells? Did you hear about Haller cells? Haller cells, these are infra or vital ethmoidal cells. These are located infromedial to floor of orbit. So in some patients, you may see at the floor of orbit infromedially a cell like this. So structure, let me remove this. If I see an air-filled cavity like this, infromedial to the floor of orbit, that would be Haller cell. But here it is pneumatized middle turbinate. And what is the relationship with Onodi cells? What are Onodi cells? Do you remember Onodi cells? You study all of these variants of paranasal air sinuses in your ENT classes. So you study about concha bullosa, that is pneumatized middle turbinate. Haller cells are related infromedial to the floor of the orbit. Onodi cells, remember ON for ON. These are posterior ethmoidal cells. These are posterior ethmoidal cells. These are posterior ethmoidal cells that are related to optic nerve, related closely to optic nerve. Right? So these are related at the posterior part, the optic nerve, they are related. So this is Onodi cells. So Onodi cells are related to optic nerve. These are posterior ethmoidal cells. Haller cells are infraorbital ethmoidal cells, whereas pneumatized middle turbinate is what is called as concha bullosa. Concha bullosa. Now identify the sequence of MRI. First of all, you should know that the fat is white and the bone is black. The bone is dark. If the fat is white and the bone is dark, black, this is MRI. This tells you it is MRI. If it was T1, the fluid will be dark in T1 and white on T2. World War II. Water is white on T2. Water is white on T2. Right? World War II. Water is white on T2. But if it was T1, the gray matter, they go by their name. Gray matter will be gray and white matter will be white. If it is T2, they're opposite to their name. Gray matter will be white and white matter will be black. Gray matter will be white and white matter will be black. They're opposite to the name. They go by the name in T1. They are opposite to the name in T2. So let me look at the image here. I know this is MRI. Let me look at the outer gray matter. Gray matter is white and look at the white matter. White matter is black. So it is same as T2. It is same as T2. But look at the fluid signal. The CSF is suppressed. So the fluid is suppressed. It is same as T2 with fluid suppression. A sequence of MRI which is same as T2 with fluid suppression. This is called as flare MRI. Fluid same as T2. Why am I calling it same as T2? Gray matter is white matter is black. Same as T2. But fluid is suppressed. With fluid suppression, the CSF will be dark. With fluid suppression. Now remember, if you compare T1, T2, look at the white matter and look at the fluid CSF. They're opposite. Always the fluid and the white matter are different colors. But if you see that the white matter is also black, fluid is also black, the ventricle is also black and the white matter is also black, this is flare MRI. Flare MRI, the fluid is also dark and the white matter is also black. So when you have a appearance where both of them are black, that is flare MRI. For what condition do we use flare MRI? Can you tell me when do you use flare MRI? For which condition do we use flare MRI? Flare MRI is useful for multiple sclerosis. Multiple sclerosis. Multiple sclerosis. Right? Flare is used for multiple sclerosis. What is susceptibility weighted imaging? What do you see in susceptibility imaging? You see jet black vessels. Okay. And one more important finding in susceptibility imaging is the presence of this dark areas. What do you call this? These are called as blooming artifacts. Blooming artifacts. So susceptibility weighted imaging shows you blooming artifact. And blooming artifacts are shown by which structures? They are shown by calcifications, hemosiderin, and microhemorrhages. Microhemorrhages. So that is how you have to identify the sequence here. So this is flare MRI. Flare MRI. I hope you got this correct. Now let's come to the next one. This is easy one. That is something repeatedly, discussed in most of your classes. A 25-year-old male met with road traffic accident is brought to casualty. GCS score is low. He has raised ICT. No significant changes are seen on CT scan. Few petechial hemorrhages. So GCS is low. Unconscious patient with CT scan appearing normal or just petechial hemorrhages involving the corpus callosum, the white matter bundle, the corpus callosum. Spinal imaging is also normal. What is the probable diagnosis? This is diffuse axonal injury. Remember, CT scan can be normal or shows petechial hemorrhages. Petechial hemorrhages. The investigation of choice is MRI. This is diffuse axonal injury. Diffuse axonal injury, right? Scivora is spinal cord injury without radiographic abnormality. Spinal cord injury without radiological, not radiological, without radiographic abnormality. X-ray CT will appear normal. MRI will show the problem. And for Scivora, investigation of choice is also MRI. Involves cervical spinal cord. So it's like this. Some children, young children, when they have trauma, they fell, imagine this person fell on his neck. And after that, he's having quadriplegia. All the four limbs are not working. The X-ray, CT scan, they don't show any problem. But when you get MRI done, the cervical spinal cord will show the pathology. They'll show stretching over the cervical spinal cord. In young children, when they have this soft bones, right? So there will be a lot of flexion happening, but all of them come back and align because of elasticity of the bones in young children. So usually occurs in very young children. So usually children, when they fall and have injury to the neck, they have quadriplegia. But when you do X-ray, CT scan, everything looks normal. But when you get MRI, the cervical spinal cord shows the injury. This is called Scivora, spinal cord injury without radiographic abnormality. And the leptomeningeal cyst, this is also known as growing skull fracture. This is growing skull fracture. What happens basically is young children, when they have a skull trauma, imagine there is a skull trauma. And after a few days, when I look at the repeat X-ray, I expect the fracture to heal. But instead of healing, the fracture actually becomes bigger. This is called growing skull fracture. And the reason this is there is because of leptomeninges getting trapped. The leptomeninges get trapped at the site of fracture and they form a cyst that will keep displacing the fracture fragments called as growing skull fragment. Normally, fracture should decrease. After a few days, when you take a repeat X-ray, the fracture should decrease. But here, actually, the fracture size appears to be increasing. This is called as leptomeningeal cyst or a growing skull fracture or leptomeningeal cyst. Is this clear, all of you? And posterior reversible encephalopathy syndrome, Press syndrome, this occurs, right, involving the occipital lobes. This occurs in pregnancy because of poor blood supply after, hemorrhage, pregnancy, patients after postpartum hemorrhage, right? They may develop this poor perfusion of the occipital lobes of the brain. That is called as Press, right? So usually after blood loss during pregnancy. Clear with this? Is this okay? GCS means score of 3, yeah, unconscious, poor Glasgow coma scale, right? So he's in coma. So he's unconscious patient, poor Glasgow coma scale. The answer is diffuse axonal injury. Now this, a 30-year-old female presented with headache and vertigo. What is the image, first of all? Can you tell me what is the image showing you? You have to be responsive. If you want me to complete fast and give you time to study, you want me to be fast. Meningioma. So you know this is a meningioma. You can see a broad base towards the dura. It's a very enhancing lesion. You can see the surrounding dura is thickened, called as dural tail sign. So it is also in female population. So meningiomas, these are more common in females because of progesterone receptor positivity. They have a broad base towards dura. They're attached towards the dura, either the falx cerebri or the convexities of the brain. They're always near the dura mater, wherever the dura is there. And they have a thickening of the dura called as dural tail sign. And you have a mother-in-law sign. So these are the two radiological signs that you see with meningioma. Mother-in-law sign is a contrast enhancement, early to come and late to go. Right? Mother-in-law we discussed is early to come and late to go. Contrast. The contrast enhancement pattern, which is having early enhancement and delayed washout. Early enhancement and delayed washout. This is called mother-in-law sign. And NF2 is Miss Me lesions. What is Miss Me? Multiple inherited schwannoma, meningioma, ependymoma. Multiple inherited schwannomas, meningiomas, and ependymomas. So this answer is what is NF2. The next one we have. What is the answer that is written for this? What did you write this answer? Simple one. So a female fell down and met with an injury at the head. CT scan was performed. What is the likely diagnosis? On a CT scan, you see a crescentric area. Great, it is crescentric. Concavo-convex, which is crossing sutures. Does not cross midline. So it is not crossing midline. All of this is suggestive of what? SDH. Okay, subdural hemorrhage. So this is acute on chronic SDH. So this is the acute part, which is hyperdense. This is the chronic part, which is hypodense. So acute bleed is hyperdense. Acute bleed is white, hyperdense. And chronic bleed is hypodense. Okay, so this is acute on chronic SDH. Right. Let's come to the next one. A 22-year-old female, right? More than 20 years. Means mature skeleton. Means fused growth plate. And you see a lesion in the epiphyseal area, just under the joint, subchondral area, and in the fused growth plate. You can see the growth plates are appearing fused, mature skeleton. All of this is suggestive of giant cell tube. Chondroblast, this is in the epiphysis. Chondroblastoma is also in the epiphysis, but this is usually less than 20 years, unfused skeleton. So giant cell tumor is epiphysis, but this is always about 20 years. Whereas chondroblastoma is also in the epiphysis, but this is below. There are there are two tumors that occurs in the epiphysis. ECG, epiphysis, you have two tumors. One is chondroblastoma and one is GCT. Chondroblastoma is in the epiphysis in the upper humerus. Femur will be in lower femur, GCT in lower femur or distal radius also. Most common bone tumor in distal radius is also GCT. This is less than 20 years, immature skeleton or unfused growth plate, mean the same. This is more than 20 years, mature skeleton or fused growth plate, mean the same, right? So that is about it. And simple bone cyst will have fallen leaf sign and trapdoor sign. And simple bone cyst is unilocular. Unusual bone cyst is multilocular. This is in metaphysis, right? This has fluid levels on MRI. But both of them occur in less than 20 years. So just if you know the age group, that is enough to answer this. Chondroblastoma is less than 20 years, simple bone cyst is less than 20 years, aneurysmal bone cyst is less than 20 years, right? So more than 20 years is given. The answer would be GCT. Soap bubble appearance, right? It can be multiloculated soap bubble appearance. Basically, soap bubble is a multiloculated appearance. It can be giant cell tumor. It can also be used for aneurysmal bone cyst. But the difference is giant cell tumor is in epiphysis, aneurysmal bone cyst is in the metaphysis. GCT is in mature skeleton, aneurysmal bone cyst is in case of immature skeleton, right? So all of this is what is, please. Are you clear with this so far? Is this clear, all of you? Let's come to the next one. Okay, this arrow, was it like this only, or was it correct in the question app? I don't know. I think the editing team disturbed these arrows. This arrow was actually pointed here. Correct only, sir. Okay, fine. What did you answer this? You can see here, this is the basilar artery. So if you identify the basilar artery, this structure here is the pons. So this anatomical landmark is the pons. So by identifying the basilar artery, you know the structure is pons. If you identify that pons, this is fourth ventricle, and this CSF space is prepontine cistern. And this black areas here, this is the Sylvian fissure. Okay. Right, so please identify the basilar artery. So the most important landmark to differentiate midbrain from pons. The most important landmark to differentiate midbrain from pons is the basilar artery. Next. Look at this thing. A 65-year-old male smoker presents with pain in the right arm and ptosis. X-ray is given below. What is the likely diagnosis? I told you the right approach to look at X-ray is to first look at the trachea, look at the hilum, look at the heart, domes of diaphragm, under the domes of diaphragm, under the left hemidiaphragm, this is gastric bubble. Then when you look at the lung fields, you always should move your eyes bilaterally symmetrically, right? You always should move your eyes bilaterally symmetrically so that you can identify the pathologies easily. So you look at the lung fields like that, you can easily identify this apical lung opacity that you are seeing on the right lung. And this is a smoker. He is having pain in the right arm and ptosis, elderly patient. All of this is suggestive of a mass there, right? A mass in the apical region of the lung that is called as Pancoast tumor. Okay, because of its compression of the sympathetic trunk, right? It will be leading to Horner syndrome. It will be leading to ptosis, meiosis, anhydrosis, all those things. And because of the compression of the subclavian vessels, the patient may have pain there. So apical lung cancer is what is called as Pancoast tumor associated with Horner syndrome. Can you tell me the investigation of choice? What is the investigation of choice for a Pancoast tumor? Very good, MRI, right? It is MRI. Let's come to the next one. A CT scan of 50-year-old male smoker is given who is presented with right upper abdominal pain. What is the likely diagnosis? So what you see in the image is a lesion with a floating membrane inside. Okay, so this is called as a floating membrane sign. Okay, this is also called as the serpent sign or floating membrane sign. That is feature of high dilated cyst. So floating membrane sign is seen. This is high dilated cyst. Now, by the way, how did you find the paper? Was the paper easy for you guys, moderate, or difficult? I think I taught most of these things. This is not new. Water lily sign, yeah, water lily sign. You can call it water, floating membrane sign, everything. Okay, okay, fine. Let's see. Okay, let's see. If you should learn to. Please remember, this is not to judge yourself. every exercise that we are doing here is to make your thinking right. Okay, we taught you theory for the last few days. Now the entire team is working to see that your MCQ practice, your thinking practice is on that. So don't judge yourself. Please keep thinking in how faculties are thinking, how they are analyzing it, so that you get them right on the day of exam. Okay, so let's look at the thought process here. Now, a patient presents with cough and fever for last 10 days. So cough and fever, so infective nature is there, auscultation on the right side, Krebs are shown, X-ray is given. What is the likely diagnosis? On X-ray, I can easily see when I compare the lung fields bilaterally symmetrically, I know the pathology is on the right, right lower zones probably. Now, if I look at the right lower zone, what is options here? Now, lower lobe consolidation, apical segment of lower lobe, or posterior segment of lower lobe, middle lobe, or stuff. So I have to look at with what the heart shadow is shown or not. If the heart border is not shown, right? I didn't understand. Putin has flower base sign. Flower base sign, this is water lily sign, also called as, many names are given. Okay, all of this is same only, water lily or camalote, lotus sign. All these are same, or serpent sign. Okay, just remember all of these are highlighted. So flower base is IVP image of horseshoe kidney, right? Flower base is different. But floating membrane sign, water lily sign, camalote sign, or serpent sign. These are all features of highlighted. Flower base sign is the IVP image. Okay, the shaking hand sign and flower base sign, that is for horseshoe kidney. Next thing. Now look at this image. So how to identify, is it a middle lobe or lower lobe, is by looking at silhouette sign. So this is silhouetting the right heart border, right? Silhouettation of right heart border is there. It's causing silhouetting of right heart border. So you know there is pneumonia. That much I can understand by the clinical symptoms, by the patient having this ill-defined fluffy opacity. But is it a middle lobe pneumonia or a lower lobe pneumonia is the question. I can clearly see the diaphragm. The diaphragm outline is clearly seen, but I cannot see the right heart border clearly. So because I cannot see the right heart border clearly, there is silhouetting of right heart border. Silhouetting of right heart border is right middle lobe pathology, right middle lobe pathology. Again, next easy one, infertility treatment, abdominal pain, nausea, vomiting. Ultrasound shows bilaterally enlarged kidney, right? Two kidneys are enlarged, so enlarged ovaries. And you are seeing this spoke wheel-like appearance of the stroma. There is spoke wheel stroma. Spoke wheel stroma. And if you see, the cysts are also large. They're not small follicle, they're large cysts. They're large cysts. All of this in a female who's receiving infertility treatment, injections of HCG as a part of infertility treatment. This is OHSS, right? Ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. So bilaterally enlarged ovaries, spoke wheel-like stroma, large cyst. Remember, there will be hemoconcentration. There are capillary leak and hemoconcentration and thrombosis. Effusions. All of this can occur with ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Thecal uterine cyst also has similar appearance, but thecal uterine cyst is due to endogenous HCG. Endogenous HCG. You will have either multiple gestation or you have molar pregnancy, right? So simple one. So do be careful if it was mentioned patient is multiple gestation or hieratiform mole, answer should be ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. Polycystic ovarian syndrome will not have large cysts. Okay, polycystic ovarian syndrome is misnomer. It does not have multiple cysts, right? It has small follicles. Follicles are there, small follicles, less than 10 mm, and the stroma is thick. The stroma is thick and follicles are small. So this is how you have PCOS. PCOS will have large stroma, thick central stroma, right? And small follicles in the periphery, not large cyst. Here you have large cyst, spoke wheel-like stroma. All of this is OHSS. Infertility treatment is mentioned, right? Treatment of infertility. All of this is classic OHSS. Next thing, look at this here. A 55-year-old male, progressive breathlessness, shortness of breath, traction bronchiectasis. So when you see traction bronchiectasis, progressive dyspnea, you know this is interstitial lung disease, bibasal fibrosis, all indicative of pulmonary fibrosis, right? So loss of volume of lungs. So it's classically telling that this is interstitial lung disease progressing into pulmonary fibrosis. Pulmonary fibrosis. Bibasal reticulation is a feature of pulmonary fibrosis. Barium swallow shows dilated patulous esophagus. And what is the most likely diagnosis? So basically, the patient is having a poor contraction of the esophagus also. There is a dilated patulous esophagus. There is dysphagia in the patient. Dysphagia because the esophagus is becoming dilated. Okay, so you know there won't be much of contraction. All of this is suggestive of systemic sclerosis, right? Systemic sclerosis. You have pulmonary fibrosis, you have Raynaud's phenomena, you have Crest syndrome, all of that, right? So here it is showing that the muscle is replaced by fibrous tissue in the esophagus. So when the muscle is replaced by fibrous tissue, the esophagus is not very contractile. Muscle is contractile, not the fibrous tissue. So the esophagus does not show much of peristalsis, right? You have a dilated patulous esophagus, right? Okay, this is systemic sclerosis. So what you need to understand is to detect interstitial lung disease or pulmonary fibrosis by looking at bibasal reticulation, right? Progressive dyspnea in the patient, traction bronchiectasis. So it's a progression of the interstitial lung disease into pulmonary fibrosis, right? Sailabanu, which PDF I have not sent to you? Are you not in the group? I have sent every PDF of radiology that I use, right? Which I said I will send, I'll not send. You guys blame without so easily. I have sent, I think. Okay. No. Or it has become a trend or what? We will not take you seriously then if you guys do like this. Okay. Just okay. Fine. CT abdomen. CT abdomen of a 70-year-old male presenting with abdominal distension shows intraperitoneal collection with enhancing septa, omental thickening, and scalloping of liver border. Now, what he is talking about all of this. So when you have a patient, which is an elderly person, showing abdominal distension, intraperitoneal collection, with thick septa, omental thickening, scalloping of liver border, right? So in the liver, so much of in the liver, you have this thick collection with omental thickenings, all of these, right? Ascites in the patient, omental thickenings and stuff. All of this is suggestive of pseudomyxoma peritoni. These words indicate pseudomyxoma peritoni. Pseudomyxoma peritoni is occurring with mucinous carcinomas of ovary and appendix. So mucinous cystadenocarcinoma of the appendix and mucinous cystadenocarcinomas of the ovary, they are associated with this pseudomyxoma peritoni. Pseudomyxoma peritoni. Okay, so these are seen with mucinous cancers of the ovary and the appendix. So the classic description, omental thickening, scalloping of the liver border by the ascites, all of this is mucinous cystadenocarcinoma of the appendix or the ovary. Pseudomyxoma peritoni is described. So the description is of pseudomyxoma peritoni. Okay, rat bite erosions are seen. So when you have in the great toe some rat bite erosion and overhanging edges. So on the great toe, you have such rat bite erosions and overhanging edges. These are called overhanging edges. What are these called? Martel sign. Martel sign. So Martel sign and rat bite erosions. These are features of gouty arthritis. Okay, gouty arthritis. Rat bite erosions and Martel sign. These are features of gouty arthritis. Next. This I hope everybody must have got it right. So there is a newborn child who is having periventricular calcification. So this congenital infection producing periventricular calcification is CMV, cytomegalovirus. Cytomegalovirus. Now, what is the likely diagnosis based on the radiograph? This simple anatomy. This is the femur. This is the patella. This is the tibia. This is the fibula. Right. So you are seeing a avulsion fracture of the tibia. Tibia fractures of two types. So either they can be a stellate fracture due to direct injury. Direct injury produces stellate fracture. Right. Stellate fracture, star-shaped fracture. And an avulsion fracture which produces a avulsion because of the pull of quadriceps tendon. This produces a avulsion fracture. Okay, avulsion fracture. And for direct patellar fracture, you go for patelectomy, right? So you cannot treat this properly. A lot of erosion and arthritis will develop, right? Here you go for figure of 8 tension wire binding, right? Figure of 8 tension wire. So what is shown here is an avulsion fracture of the patella. So it's an avulsion fracture of the patella, right? Some issue, some okay. How periventricular calcification is CMV. Okay, naturally. Toxoplasmosis will cause diffuse nodular calcifications, right? Diffuse nodular calcification. We haven't sent the day 3 PDF. Rupesh, I had sent. Let me. I have already sent every PDF. You must be missing, Nachalam. You message me after the class. Okay, I will see to it that you receive it from your side. Okay, so because as far as I remember, I've sent every PDF in the group. But in case you're missing it out, please message me tonight after the class, and I'll get back to you. Are we clear with this? Figure of 8, tension wire bending. Okay. Okay. All PDFs in the group. Okay. Next thing. What is anatomical variant in the given CT scan? So this is a difficult question for you guys, but because it has come up in the recent Indian exam, I thought I'll just discuss it with you. So let us look at what is being shown here. He's asking you there is an anatomical variant that is shown. And what is it showing? A blood vessel. So it is showing a blood vessel that is showing. And where is it going? Posterior to the esophagus. This is the trachea. This is the esophagus part. It is going posterior to the esophagus. So basically, it's a blood vessel coming from the arch of aorta. You know the arch of aorta, a blood vessel that is coming and going posterior to the esophagus. So this is aberrant right subclavian artery. It will produce compression of the esophagus, producing dysphagia lusoria. Dysphagia lusoria. Right side aortic arch, this is the right side. This is the left side. So aortic arch is on the left side only, not the right side aortic arch. Right? So you're seeing a blood vessel which is going posterior to the esophagus, compressing the esophagus. I hope you remember we discussed this in angiography. So you have your right common carotid, left common carotid, left subclavian, and then you also have a right subclavian. So right subclavian artery, which is originating below the origin of left subclavian, going behind the esophagus. It is going all the way posterior to esophagus, compressing the esophagus posteriorly. So this is the esophagus. It goes behind the esophagus, compressing the esophagus. So you are given a section here which is showing the blood vessel going posterior to it. This is aberrant right subclavian artery. This is dysphagia lusoria. Dysphagia lusoria. Next thing. Okay. Here I think the number was missing. I thought we should keep the mock exam as close to the real exam. So we kept like that. And also when you're practicing your test and discussions, right? So you should switch off your ACs, your fans, and sit and write your TNDs so that you'll be in the right exam, mood when you're writing your, exam. Anyways, tell me what is 1 by these marked arrows now. So let me mark it for you now. Let us try to do this in this with me. This is 1. This arrow is 1. What is 1 showing you? What is 1 showing you? 1 is showing you. I'll ask that, we'll give it marks to anything that you have answered, we'll give you the mark. So add 1 mark for whatever you've answered, but still just try to see what is 1 here. So 1 here is pointing to the pulmonary artery, right? So this is 1, right? What is 2? 2 is marking to the superior vena cava. 4 is the main pulmonary artery. 3 is the ascending aorta. 3 is the ascending aorta. Descending aorta is this one. This is descending aorta. This is descending aorta. Okay, let me label it here only for you. So based on where the arrow was there on the day of exam, you mark it. So this is the right pulmonary artery. This is the main pulmonary artery. This is the left pulmonary artery. Okay. This is the left pulmonary artery. This is the descending aorta. This is the ascending aorta. And this vessel on the right side is superior vena cava. I told you this thing that you have a right and left brachiocephalic vein uniting and forming superior vena cava. Then you have your arch of aorta, ascending aorta, descending aorta. Then you have a main pulmonary artery dividing into right and left branches. You have your main pulmonary artery dividing right. So you've taken a section here. So this is ascending aorta. This is descending aorta. To the right of ascending aorta is superior vena cava. To the left is main pulmonary artery dividing into right and left branches. So the marked arrow. Okay, anything you have marked, you do it correctly. So identify the number in the given image. You just be careful with this slice. Okay, this slice is important. So which is ascending aorta, which is descending aorta, which is superior vena cava, which is main pulmonary artery. which is right branch and the left branch. Okay, let's come to the next one. This is simple. You are having a patient with the elderly patient with weight loss, regurgitation, halitosis, and dysphagia. A barium study shows you a narrow bird beak-like appearance. So bird beak appearance is achalasia cardia, achalasia cardia. I told you CA esophagus would have irregular shouldering. So unless you see that irregular shoulderings, right? So irregularities and all. So don't mark CA esophagus. Okay. So even in achalasia, you have weight loss. Right? Achalasia, you'll have weight loss, you have lack of relaxation of the sphincter, so halitosis because of the regurgitation that is occurring. All of this will be there. So this is achalasia cardia, achalasia cardia. Here the image you have to correlate. Halitosis will occur in Zenker's diverticulum, I agree, but there is no image of that, right? And no option of that. So halitosis, if there was a barium study here showing a pharyngeal pouch, I agree. But here it is not showing that. And achalasia also, because the contents are in the esophagus only, and these contents are getting reflux, you may develop this. Okay. And feline esophagus, what do you see? Feline esophagus, what do you see? What do you see? Where do you see feline esophagus? Where do you see feline esophagus? Okay, be careful tomorrow. Okay, try to see the irregularities, the shouldering to mark CA esophagus. Feline esophagus is seen in gastroesophageal reflux disease, right? So you have that mucosal shiver, esophageal shiver. There will be circular mucosal folds on the lower esophagus. There is a esophageal shiver, a transient esophageal shiver will be there. Esophageal shiver also you call it, esophageal shiver, right? In the distal esophagus. Right, so this is all about feline esophagus. Gastroesophageal reflux disease has feline esophagus. Next, what is the interventional radiology procedure for aneurysm? For aneurysm, right, we do endovascular coiling. So whenever we have a vascular aneurysm like this, you are having a risk of rupture of the aneurysm. So what we do is we go with a catheter and we put these platinum coils here, right? So we do endovascular coiling, so that the risk of rupture is less, and this gets thrombosed because of all these coils that are kept inside. There is thrombosis and non-functioning of this aneurysm. So this all gets thrombosed and you don't have risk of rupture of the aneurysm. So that is what is endovascular coiling. You go in the vessel and put a platinum coils in that area of the aneurysm so that it gets thrombosed and does not rupture. So that is endovascular coiling. Can you tell me where do we do tear? Transarterial radioembolization. Anybody? You go through the artery. You go through the artery and do radioembolization. Did you hear about this procedure anytime? You enter into the artery and you give yttrium 90. Okay, we use yttrium 90 to cause this radioembolization by using yttrium. This is used in hepatic artery. The transarterial is in the hepatic. And what does hepatic artery supply? The HCC. Right? So you enter into the hepatic artery and do radioembolization with yttrium for HCC. So TARE is a procedure that is done for hepatocellular carcinomas. Hepatocellular carcinomas. Next, what is the management of this thing? This is classic EDH, and for EDH you need to go for surgical evacuation, that is craniotomy. Okay, burhole or craniotomy should be done. Right, so this is EDH. Okay, this is slightly tricky, but if you think over, you can get it. Child presented with abdominal discomfort with intermittent abdominal pain, what is the likely diagnosis based on the radiograph? So if you see the radiograph carefully, you can see, and even the arrow was there, that is pointing towards this opacity on the right side and on the medial part, not on the lateral part, on the medial part. And this is a condition of the bowel loops of the abdomen. If you see, it's a condition of the bowel loops in the abdomen. So this is a diaphragmatic hernia, which is on the right side and anteromedial side of the, hemithorax, right? Anteromedial. This is Morgagnis. Morgagnis is right anteromedial. Bogdell-X is left posterolateral, and this is most common, I agree, but this is on the left side. So if you see on the left posterolateral side, bowel loops in the left hemithorax, like that, that would be congenital diaphragmatic hernia, Bogdell-X hernia. But here this is Morgagnis hernia. Gastric volvulus would have Bouchard strat, right? So you have the classic retching without vomiting, epigastric pain, Bouchard strat. And you will see the coffee bean-like appearance at the epigastrium, right? So you have retching without vomiting, inability to pass the nasogastric tube, you have epigastric pain, all of this will be there. That is gastric volvulus. Diaphragmatic eventration also, again, the diaphragm will be much higher, right? So the diaphragm will appear much higher and the bowel loops will come there, right? So that is diaphragmatic eventration. This is right anteromedial side. This is Marcagni's hernia, right? Marcagni's hernia. And diaphragmatic eventration will occur after trauma. No trauma is mentioned, child is there, so congenital problem. This is Marcagni's. And all this congenital diaphragmatic hernia is due to defect in which structures? Defect in which structure, guys? Defect in pleuroperitoneal membranes. Pleuroperitoneal membrane. Right? Pleuroperitoneal membrane. Yes, that is what it is. Bogdalex is left posterolateral. Marcagni's is right anteromedial. That is the main difference between Bogdalex and Marcagni's, the location. Okay. What is the most sensitive for parathyroid imaging? Remember, for localization of parathyroid adenoma. So, localization of parathyroid adenoma. I would strongly recommend, if you have not revised it, so see that you just flip through the radiology workbook that I have taught you. Okay, go through that. It will help you with a lot of your subjects. At this point, you'll even understand better after doing the other subjects. You'll also appreciate what we have done together. Technetium 999, Sestamibis spec. This is the investigation of choice, okay, for localization. This is better than only 4D CT, and this is better than only Sestamibis. Obviously, SPECT is 3D imaging. SPECT will be better. If you compare between these two, SPECT is 3D. So 3D will always be better than only technetium. So do not mark Sestamibis, mark SPECT if it is there in the options. Right? So Sestamibis SPECT. And if 4D CT is there, go with 4D CT. 4D CT plus Sestamibis is there, go with 4D CT plus Sestamibis. This is the order that you have to follow for localization of parathyroid adenoma. So localization of parathyroid adenoma, 4D CT plus Sestamibis SPECT is better than only 4D CT. That is better than Sestamibis. Don't mark if CT is given. Only 4D CT is mentioned. Clearly, the word 4D is mentioned. Then only you answer it. Otherwise, choose Sestamibis SPECT. Don't mark if CT scan is there and come and argue with me tomorrow. Okay. Do not mark CT scan. Mark only when there is 4D CT. 4D CT. Is this clear, all of you? SPECT is 3D imaging. So it will be better than only Sestamibis. Okay. Be careful with that. Next thing. A HIV positive patient. So it is an HIV positive or AIDS patient that you have, right? And MRI is showing this multiple ring enhancing lesions, right? So these are all ring enhancing lesions, right? Ring enhancing lesions in the basal ganglia. Ring enhancing lesion in AIDS patients, in basal ganglia especially. All of this is classic of toxoplasmosis. Tuberculosis or TB meningitis has basal exudates. Tuberculosis will produce lipid lactate peak. It will have conglomerate fused ring enhancing lesions, right? Multiple ring enhancing lesions will show you the lipid lactate peak, lipid lactate. And here, because the location is the basal ganglia and you are seeing ring enhancing lesion, AIDS patient is mentioned, the better answer is toxoplasmosis. Cryptococcosis will have soap bubble appearance. Okay, Cryptococcus will have soap bubble appearance on MR. Soap bubble appearance. And metastasis will not be in this area, they will be in the periphery at the gray white matter junction. Gray white matter junction. So these are the different ring enhancing lesions. Next thing. Next, this I taught you in the classes also. A 9-year-old brown skin rashes, that is cafe au lait spots. Brown skin rash means cafe au lait spot. Right? This can be seen in NF1 or this can be seen in McCune Albright. NF1, you have a smooth coffee colored spot, whereas neurofibroma and McCune Albright will have a regular coffee colored spot. It has multiple bone lesions also. There is increased uptake on bone scan, and you're seeing the radiograph. You're seeing a Shepherd-Crook deformity. You're seeing Shepherd-Crook deformity. Right? So all of this suggests this is fibrous dysplasia. Fibrous dysplasia that you're seeing. So fibrous dysplasia, cafe au lait spots, right? Precocious puberty in a young female. All of this suggests your McCune Albright syndrome. McCune Albright syndrome. So McCune-Albright syndrome will be having a combination of café spots, that is brown color spots. We are having polyostotic fibrous dysplasia, multiple bony areas, polyostotic fibrous dysplasia. Fibrous dysplasia is the hot uptake on bone scan. There is proliferation of the cancellous bone. There is proliferation of the cancellous bone, so hot uptake on bone scan, right? So all of this I have discussed in the classes. Nothing is new, so just consider it. Café spots, polyostotic fibrous dysplasia, and we also have a, for the other thing, precocious puberty in a female. Precocious puberty in females. All of this is McCune-Albright syndrome. McCune-Albright syndrome, right? Next one. Patient comes to emergency with severe abdominal pain. A erect chest radiograph is shown to you, and you see air under right hemidiaphragm. Air under right hemidiaphragm. This is suggestive of hollow viscous perforation on pneumoperitoneum. And many of these patients are in the shock, right? So they'll be in hypotension and shock. The treatment will be resuscitation and emergency laparotomy. Not just laparotomy, resuscitation and emergency laparotomy. That is, IV fluids and laparotomy should be done for hollow viscous perforation on pneumoperitoneum. Okay, pneumoperitoneum. Next, a pancreatitis patient X-ray shows you whiteout lungs. There is very less black area. The lung volumes are reduced. All of this is suggestive of ARDS. So whiteout lungs, decreased lung volume. This is ARDS. Okay, ARDS. It can occur with pancreatitis, sepsis, right? It can occur with surfactant deficiency. All of this, okay, can cause this ARDS. Next, a fever patient having temporal lobe involvement on MRI. The most common lobe involved is temporal lobe in herpes simplex encephalitis. Right? So the most common lobe involved in is what? Herpes simplex. Japanese encephalitis involves bilateral thalami, not temporal lobes. Varicella involves cerebellar hemispheres. Posterior cerebellar hemispheres are involved. Right? Cerebellum is involved in case of varicella encephalitis, whereas herpes simplex involves temporal lobes. This is easy. So when you're given sterile pyuria in the question, right, loin pain, sterile pyuria, you're seeing a calcified kidney. This is putty kidney. This is renal TB, renal tuberculosis. This is putty kidney. Nephrocalcinosis, these resemble renal pyramids. If it resembles renal pyramids, calcification resembles the renal pyramids like this. This is nephrocalcinosis. Renal pyramids. And medullary nephrocalcinosis, the medullary nephrocalcinosis is seen with medullary sponge kidney and hyperparathyroidism. Right? Staghorn calculi, on the other hand, will resemble the pelvic calcium system. Right? So this is the pelvic system. So how the appearance is there is also important. So if you see, and the classic history is there, right? Loin pain is there, sterile pyuria is mentioned. This is renal tuberculosis. And what is the finding that you see in renal tuberculosis? Putty kidney and cement kidney. This is putty kidney. Next thing. Here you're having a hypertensive patient, right? Most common cause for aortic dissection is this irregular, poorly controlled hypertension. You have pain radiating to the back, the interscapular region, chest pain radiating to back, the interscapular region, scapula. And blood pressure, there's differential pressures in both the upper limb. One upper limb is having more pressure, other upper limb is having less pressure. Left has more pressure, right has less pressure. There's differential pressures in the upper limbs. And there is mediastinal widening, right? Aorta is in the mediastinum, right? In the superior mediastinum, you have the arch of aorta. So all of this is aortic dissection. So you are seeing chest pain radiating to back. This is aortic dissection. What is the investigation of choice, guys? What is the investigation of choice for aortic dissection? If I ask you, instead of asking a diagnosis, if I say, what is your preferred investigation to be done in this patient? Or what is the investigation of choice for this patient? What would your answer be? What is the investigation of choice for acute aortic dissection? You go for CT angiography. aortic dissection and pulmonary thromboembolism. The investigation of choices, CT angiography. CT angiography. Can you hear me? All of you. All of you are clear? Or is it very fast? Is it manageable? Okay, fine. So this is unstable patient. This is unstable patient. And in case of unstable patient, we go for transesophageal echocardiography. Transesophageal echocardiography in unstable patients. Next. A newborn child with a abnormal lump in the lower back. And this is T1 with imaging. This vertebrae are black. The vertebrae are black. Both of them are MRI. Right? The question also mentions MRI. The CSF around the spinal cord is black. The CSF around the spinal cord is white. So this is T2 weighted MRI. And in that, I can see a cystic lesion. Cyst is dark on T1, white on T2, and it is also showing the neural elements entering into it. So it's not just cystic area, but nerve fibers also entering into it. So it's not just meningocele. This is myelomeningocele. Remember, myelomeningocele is seen with Chiari-2 malformation. Chiari-2 malformation, right? So this is myelomeningocele. This is classic young male with low backache and having other inflammatory conditions. This is inflammatory arthritis. This is ankylosing spondylitis showing bamboo spine. And this is the dagger sign, calcified interspinous segment, right? Interspinous ligament. And together is called as trolley track or tram track. Trolley track or tram. So all these things together. So calcification of the periphery of the intervertebral disc, this is bamboo spine. Calcification of the interspinous ligament, this is dagger sign, together called as trolley track or trap track sign. This is ankylosing spondylitis. Next, a delayed intravenous urogram is shown. What is the likely diagnosis? So this is not a plain study. This is contrast study. It's a urogram, delayed urogram, contrast intravenous urography study that is given to you. So you're seeing that on the left side, the right side, the pelvis, and this is the ureter that you're seeing, right? And here you can see the dilated pelvis, and I'm not seeing the ureter. That means there is some kind of obstruction here at the pelvis and the ureter, that is pelvic junction obstruction. So this is pelvic junction obstruction. There is a dilated pelvis and there is obstruction in the ureter. You're not seeing the ureter. This is pelvic junction obstruction, PUJ obstruction. Staghorn calculi would be a plain radiograph. This would be plain X-ray, not a urogram, and this would resemble pelvis, resemble pelvic calcium system. Right? So, but that would be plain X-ray. Here it is contrast study. You can see the dilated pelvis and the absence of ureter that side. I mean, non-visualization of the ureter, because it is obstruction. The contrast is not going to the ureter, so you're not seeing the ureter that side. That is PUJ obstruction. This is two separate cervix. When you have two separate cervix, two separate catheters that you are seeing, two cervix separately. This is didelphus. Okay. Bicornuate will have only one cervix. Okay. Bicornuate will have one cervix. Unicornuate is banana shape. Okay. And septate will have narrow intercornual angle. Narrow angle. Bicornuate will have wide angle. You know this. So because there are two cervix, didelphus will have two separate cervix. This is didelphus. Why not A? For which one you are saying? For which one you are seeing? Which question? Staghorn calculi. 38 you are saying. Okay. 38 because it is not plain X-ray. It is delayed intravenous enogram. Right? That is the reason you are saying it. Pelvic it's contrast that is there. Not going out. यूट्रस वाला यूनिकॉर्नुएट में तो एक ही है ना, या दो दिख रहे हैं ना. यूनिकॉर्नुएट एक ही बनाना शेप होता है, एक ही होता है बनाना शेप, दो नहीं होते. यूनिकॉर्नुएट, राइट? ओनली वन हॉर्न, राइट? दिस इज हाउ टू सेपरेट आर. Next thing, coming to types of radiotherapy that we have. The fractionated or regular radiotherapy, this is 5 days a week, Monday to Friday, right? OD dose, once daily dose. This is how regular fractionated or conventional, this is also called conventional radiotherapy, right? So this was FMG previous question. Are we clear? Coming to hypofractionated radiotherapy, this is less than 5 fractions per week. Hyperfractionated more than 5 fractions per week. Accelerated, you complete between 4 to 6 weeks max, and you complete within 4 to 6 weeks. So that is how you have different types of radiotherapy. The regular one is the one which is commonly used, once daily doses. Hypofractionated is used for bone metastasis. You give 8 gray in single fraction. Hyperfractionated is BD or TID doses. If you give morning and evening, twice daily, thrice daily, that is called hyperfractionated. Whereas accelerated is within short duration you complete it. So that is all about the different types of radiotherapy. Yes, hyperfractionated is not that is continuous. Hyper means you are giving continuous. If you are giving continuously, including Saturday, Sunday, that is continuous one. Hyperfractionated means more than 5 fractions. It can be either twice daily, thrice daily doses, BD or TID doses. That is what is meant by hyperfractionated. Okay. What you're telling about is continuous. If you give Saturday, Sunday also, that is continuous. This is not on Saturday, Sunday. This is more on the same day you're calling, in the afternoon also, in the evening also. That becomes hyperfractionated. BD or TD means twice or thrice daily. Twice or thrice daily. Right? And that is hyperfractionated. Next thing. This is a HIV positive patient, and you're seeing fever, dyspnea, cough. X-ray shows bilateral lung field showing millet seed-like opacities. Bilateral millet seed-like opacities. This is miliary TB. Right? So miliary TB. What are the other causes of miliary mottling? You can see this in histoplasmosis also. So why not histoplasmosis? Because you have to choose the more common. Immunocompromised person, bilateral lung fields are showing opacities. You have to choose the more common ones first. Okay, so miliary TB. But can also be seen in histoplasmosis, sarcoidosis. It can be seen in cases of mitral stenosis also, along with miliary TB. Right. So along with miliary TB, this can be seen with other conditions. But why not histoplasmosis? Because it is a rare cause, right? More commonly, you should think of the common causes. TB is more common. Miliary TB in AIDS patient, HIV positive patients are more common. So first, you should think for the more common causes first. Okay. Next. Did you do this correctly? 25-year-old male patient presenting with abdominal pain, blunt trauma abdomen, road traffic accident. BP is stable, pulse rate is okay. What is the next step in management? So please remember, he's asking next best step. Whether the patient is stable or unstable. Whenever a blunt trauma abdomen patient comes, the first investigation has to be EFAST or FAST. Right? So that is ultrasound, sonography. If the FAST is positive, that there is hemoperitoneum, you look for the vitals. Vitals are stable, go for CECT. Vitals are unstable, go for emergency backup. So this is all done only after FAST is said to be positive. So please remember the first investigation, whether the patient is stable or unstable, the first investigation that you need to do. So he did not mention anything about ultrasound or FAST. He's asking what is the next best step in the management. It has to be EFAST. So this is ultrasound. Are we clear with this? Next thing. Radiographic signs of left atrial enlargement. What is radiographic signs of left atrial enlargement? Now, obviously, left atrium when it enlarges, aortic knuckle, pulmonary artery, left auricle. So this left auricle becomes enlarged. So there is an enlargement of left atrial appendage that causes straightening of left heart border. This causes elevation of the left main bronchus. Because this is getting enlarged, it will cause elevation of left main bronchus, causing splaying of carina, called as walking man sign. Splaying of carina, walking man sign. It appears like a walking man. And because this is the third bulge, first, second, third bulge that becomes prominent, that is called third mogul on just X-ray. And left atrial enlargement, when it occurs, the heart border on the right side appears too. So this is called double right heart border. Double right heart border. So straightening of left heart border is the earliest finding. Elevation of left main bronchus, splaying of carina. Okay, right? You have a walking man sign. You have a double density sign, double right heart border. You have a third mogul on just X-ray. So the correct answer is all of the above. All of the above. We discussed this signs of left atrial enlargement or mitral stenosis. Please go to this topic again. Mitral stenosis or left atrial enlargement. Enlargement of left atrial appendage, straightening of left heart border, elevation of left main bronchus, playing of carina, walking man sign, double right heart border. Double right heart border is left atrial enlargement. Left atrial enlargement. Okay, mitral stenosis will have left atrial enlargement. Third mogul on chest X-ray. First one is aortic knuckle, second is pulmonary artery, third mogul on chest X-ray. All of this is left atrial enlargement. Next, alcoholic patient, abdominal pain, right? Hypertensive diabetic, X-ray is shown. And the X-ray, you can see a calcification in the region of the pancreas. So, calcification of the pancreas, this is chronic calcific pancreatitis. Chronic calcific abdominal pain, calcified pancreas, chronic calcific pancreatitis. Next, pulled up cecum. Pulled up cecum, this is a feature of intestinal tuberculosis. Listen to me carefully. Normally, this is the cecum, this is the appendix. This is the ileocecal junction. Ileum, cecum. This ileocecal junction normally is 90 degrees, right angle to each other. But in case of tuberculosis, I told you there is mesenteric lymphadenopathy and fibrosis that occurs in tuberculosis. So the cecum will be pulled upwards. Imagine there are lymph nodes and this fibrosis, the cecum is pulled up. When cecum is pulled up and there is involvement of the terminal ileum, right, by the tuberculous infection, there is narrowing of the terminal ileum, thickening of the ileocecal valve, narrowing of the terminal, there is appendix like this, right? So what has happened is there is widening of ileocecal angle, obtuse ileocecal angle. There is pulled up cecum, this pulled up cecum. And this whole appearance appears like gooseneck deformity, gooseneck deformity. There is narrow terminal ileum. There is thickening of the ileocecal valves. This thickened ileocecal valves, this appears like an inverted umbrella. Right? This appears like inverted umbrella sign. Or Fleshner's. Fleshner's. Inverted umbrella sign or Fleshner's. So once again, just imagine there is fibrosis and there is a mesenteric lymphadenopathy and fibrosis. That has called the pulled up cecum. That has caused the pulled up cecum. So in tuberculosis, when you have terminal ileum involvement, you have the ileocecal involvement. There is obtuse ileocecal angle. What are the findings of ileocecal TB? There is pulled up cecum. There is widening or obtuse ileocecal angle. There is narrow terminal ileum. This is called sometimes the string sign. Okay, so string sign. And you're having thickening of ileocecal walls. This is called Fleshner's sign or inverted umbrella sign. And when I give barium, barium does not like to stay in the disease area. The barium will be flushed off fastly from this area. So that is called a Sterling sign. Sterling sign. Rapid emptying of barium. From disease segment. Once again, pulled up cecum, widening or obtuse ileocecal angle, narrow terminal ileum, inverted umbrella or Fleshner's sign. You have a gooseneck deformity of the ileocecal region. Gooseneck deformity. Gooseneck deformity. And remember, TB produces transverse ulcers. TB produces transverse ulcers. Whereas typhoid produces vertical ulcers, longitudinal ulcers. So because it produces transverse ulcers, TB produces transverse ulcers. So these transverse ulcers, they start healing, and when they heal, they produce fibrosis that will cause napkin ring-like appearance. Okay, napkin ring-like stenosis will occur. Right. So because of the transverse ulcers getting fibrosed, you get a napkin ring stenosis. All of these are features of ileocecal TB. Once again, typhoid will have longitudinal ulcers, whereas TB will have transverse ulcers in the GI tract. In case of TB, because of the transverse ulcers getting into fibrosis or stricture, you get this napkin ring stenosis, napkin ring stenosis. All of these are important findings that you see with ileocecal TB. Ileocecal TB. Are you clear with this? The most common solid organ that is damaged in blunt trauma abdomen is spleen, right? You can rectify it with your surgery faculty, but that is what I remember, right? Spleen. Is this clear? It is ileocecal tuberculosis, correct, all of you? Fine. Let's come to the next one. Which of the following has a low T1 signal? Low T1 signal. Now, coming to low T1 signal, this is very simple. We all know fluid is dark on T1 and white on T2. That is World War II. Water is white on T2, dark on T1. So water or CSF is dark on T1. T1. And I told you what are the structures which are dark on both T1, T2. These are called signal voids. Signal voids. And what are the signal voids? A, B, C, D, F, air, bone, calcification, dense fibrous tissue, and flowing blood. What is the dense fibrous tissue? Menisci, ligaments, tendons. And what is white on T1 or hyperintense on T1? Fat MP. Fat, methemoglobin, melanin, minerals like copper, protein content, and paramagnetic substances like gadolinium. I discussed this already. So he's asking simple thing. Low on T1, dark on T1. What is dark on T1? Low on T1 means dark on T1. So fluid or CSF will be dark on. You know how to differentiate T1, T2 images. Simple question. All of these three are white on T1. Right? All of them are white on T1. The subacute hemorrhage is a stage where you have methemoglobin. Subacute hemorrhage is a stage which has methemoglobin, right? So the subacute hemorrhage, methemoglobin stage will be white on T1. Melanin, proteinaceous content, right? All of these are white on T1. CSF will be dark on T1. Now, which of the following is false about mammography? So, okay. Molybdenum anode is made up of, sorry, anode is made up of molybdenum in case of mammography. This is true statement. Tungsten is in this thing. This is true. The filter is made up of molybdenum and aluminum in X-ray. This is true. Just now I taught you, right? So the mammography M for M. Remember in your classes I taught you this. Molybdenum is used in mammography. Radiation dose in chest X-ray is about 0.02 millisievert. And in mammography is 0.5 to 0.7 millisievert. So chest X-ray has less dose. So this is false statement. Exit window is beryllium and glass thinning of glass tube in X-ray tube. This is true statement. So this is a correct answer. So you don't have to get worried. So many times the answer is a very simple question, right? But because you don't know the other options, you'll get panicked and worried about it, right? So just try to deduct the other one easily. It's a simple question. I hope most of you got this right. So remember, the chest X-ray radiation dose is 0.02 millisievert. The radiation dose in mammography is 0.5 to 0.7 millisievert. Next, which of the following is correctly matched regarding radiation units? So remember, if you look at exposure dose, you have conventional units and SI units. Conventional unit is Roentgen, SI unit is coulombs per kg. If you look at absorbed dose, it is rad and gray. If you look at equivalent dose or effective dose, both of them are REM and Sievert. And radioactivity, it is Curie and Becquerel. Right, so here all the above is correct. So absorbed dose is rad and gray, equivalent dose is REM and Sievert, exposure dose is coulombs per kg and Roentgen. So all of them are correct. Okay. How to manage? I didn't understand. Panchal, what did you ask me exactly? Is this clear so far? Okay. Next, which of the following is not true about radiation side effects? Now, I taught you this thing. There are two types of radiation side effects, stochastic effects and deterministic effects. Stochastic are genetic effects, like cancers. Deterministic effects are somatic effects, like skin erythema, or anything that occurs on the body, like GI syndromes, bone marrow involvement, right? CNS syndromes, anything, all radiation syndromes. Stochastic effects, they have a linear dose effect curve. Deterministic effects will have a non-linear dose effect curve. So stochastic effects have linear curve. This has non-linear curve. Non-linear means it has a threshold dose. So it will not occur at low dose, it occurs above threshold dose. There is a threshold dose. Threshold dose. So deterministic effects are dose dependent. Yes, it does not occur at low doses, they occur above the threshold dose. This is true statement. Stochastic effects are dose independent. This is also true statement. It occurs at low dose, it occurs at high dose, dose independent. Stochastic effects have a linear dose effect curve. This is also true statement. Acute radiation syndromes, they are stochastic effects. This is false statement. It is acute, all the acute radiation syndromes. They're all occurring on the somatic body. Acute radiation, GIT, bone marrow, CNS. All of these are on the body, right? So this is deterministic effect. These are deterministic effects. Deterministic. So this is the false statement. So he's asking you which is not true. So you have to go for this. Lastly, palpitations, headache, VMA levels are elevated. What is the best investigation for this patient? Now, basically, you know, palpitations, VMA levels, you're talking about pheochromocytoma. Please remember, the investigation of choice for adrenal pheochromocytoma is MRI. Whereas, investigation of choice for extra abdominal pheo is dopa PET better than MIBG. So the answer should be dopa PET. If dopa PET is mentioned, that is not MIBG, dopa PET. Okay, we'll correct this up. So these are the two things that we have. So you know it is pheochromocytoma. And for pheochromocytoma, for adrenal pheochromocytoma, the investigation is MRI, right? Imaging investigation, basically, I'm talking about. Okay, what I'm talking about is imaging investigation, not the biochemical metanephrines and all. I'm talking about imaging because options also does not show that. So I should not think about that. We're mostly dealing with imaging investigation. Imaging investigation of choice for adrenal pheochromocytoma is MRI and extra abdominal pheochromocytoma is dopa PET better than MIB. Dopa PET better than MIBG. I hope you have got decent questions. Most of this have been discussed. I have not kept anything much new. Everything is there in our class notes, in our workbooks that we have worked on. Right? Every single question. Okay, this GIT part is there. I'll be doing a YouTube session. Please do that session. I'll try to see we cover a lot of GIT in that, and also I try to see that all the important images we go through once. Okay, so sir, a way to remember all the bone tumors, GCT, ABC, like that. Okay. Let me tell you this simple thing that I usually do it in the classes, right? I think I've taught you that. But anyways, look at here. You have to understand what are the bone tumors in epiphysis, what are the bone tumors in metaphysis, what are the bone tumors in the diaphysis. First is to identify the location. And for this, we have a simple thing, ECG, AEO. This much, these five you remember. ECG and AEO. AEO. ECG means epiphysis is chondroblastoma and giant cell tumor. AEO is adamentinoma, Ewing sarcoma, and OO I wrote pointedly so that you remember osteoid osteum. Osteoid osteum. Right? So these five things you remember first carefully. Anything else you write metaphysis. First remember this five easily. ECG, AEO. Right? So ECG is chondroblastoma and GCT other name is osteoclastoma. So only two names, don't get confused. Simple only. What is the difference? This is less than 20 years. That is immature skeleton. This is more than 20 years. What is the common thing? Both of them are in the epiphysis. Both of them are in the epiphysis. What are the other differences? This is in the upper humerus. Usually, it can be anywhere, but usually upper humerus. This is usually lower femur. Lower femur. Right? So lower femur. This much you remember. And also distal radius. Most common bone tumor in distal radius is what this. This is about ECG and distal. Anything else you say? If I ask you where is simple bone cyst, where is aneurysmal bone cyst, right? Where is metastasis? Where is osteomyelitis, right? Where is osteosarcoma, chondrosarcoma? Anything? Where is enchondromas? You answer it as metaphysis. What is the difference? Simple bone cyst is unilocular. It's single, unilocular. Unvisible bone cyst is multilocular. Both of them are in metaphysis, right? One is unilocular, one is multilocular. So this is some brief thing that just to revise. If I hope that is fair. Next, sir, should I do FMG solutions questions? Yeah, it's a good book. You should do it. Right? It will help you solve more questions than not. Is radiology 10 marks, sir, or 5 marks? Radiology last FMG exam you had 15 marks. 15 marks in INS set you had 10 marks. 200 marks paper you had 10 marks. 15 marks. Please do radiology and go. It is my request. Okay, आप लोग का benefit वो exam में आएगा. Okay, so lot of questions are there. And I'll share you the PDF, annotated PDF. Otherwise, so one girl will be unhappy. I don't know. Okay, but for her sake, I'll have to send today itself. Okay, so I'll do that. GIT and hepatology annotated PDF. I will ask. Okay, I'll try to share. Ask ma'am Ravina ma'am. Okay, go through those topics also whenever you're free. And one more thing. Okay, don't panic and don't worry. You're doing a lot of. You all are doing what is best possible in this limited period of time. When you're doing right, don't panic, don't worry. You are much better because we are trying to do a lot, right? We'll feel that we are lagging somewhere and all. It's not lagging somewhere and all. You're trying to learn, okay, learn and evolve and know properly, right? So that is where this kind of stress will come. A bit of stress is good. That means you know a lot. I have seen people with so much of confidence just doing one book or just doing 3 4 topics and all, going with so much of positivity and all, and our students with so much of effort, so much of energy, so much of thought process done, start getting to worry, get very panicked and worried. But at the end of the day, results will come on somebody who has been patient and working hard sincerely in all of this, right? So believe in your hard work that is happening. You will be fine, don't worry. Okay, sir, sepsis का context दीजिए एक बार. Sepsis in the sense, I didn't understand. Sepsis is a big topic, right? So altogether TND में time निकल जाता है. How to manage? You are try to just cover it. Now 4:30 I have left you, right? And you have done 2 good subjects and we are studying at the same time. Don't think that is you're not utilizing time. This all have to be understood. This all have to be there, and hope so. Whatever we are discussing comes on the day of exam. Right? Cutoff for this test, I feel 25 marks is needed in this paper. It's not very difficult paper. 50% you have to score in this paper. Even if you have not scored, don't worry or don't feel sad about it, right? You have to see that those mistakes don't occur in the day of exam, right? So it's a simple one. Anat, Biochem, Pharma, Micro, PDF. These are purely faculty discretion whom to whether to share or not to share. हम लोग के पास आएगा तो हम लोग भेज सकते हैं. तो faculties, some faculties have that inhibition of sharing the PDF, so we have to just manage that. Sir, question number 43 once. 43. Left atrial enlargement. So all of the above is the correct answer. Okay, straightening of left heart border, double density is nothing but the double right heart border on chest X-ray. Third bulge is the left atrium, right? What is the score that you are getting, Vinay? It's okay. That's what I'm saying. If you're getting 25 plus 50 marks, 50% to cross करने की कोशिश करना है इस paper में. It's not a difficult paper. It's just of little application and all. So you should try to reach 25. Okay. No issues. Okay. Without revision अगर नहीं पढ़े तो obviously कम आएंगे marks. तो थोड़ा बैठ के कभी PDF एक बार फास्ट ट्रैक कर लेना, हो जाएगा. एनीवेज हम लोग फिर से एक बार मैं थोड़ा सा फिर से रिवाइज कराऊंगा. देयर आर ऑन YouTube देयर आर टू वीडियोस. इफ यू वांट टू लर्न जस्ट बाय डूइंग रेट्रोग्रेड एमसीक्यूज, रेडियोलॉजी को आप ज्यादा वो नहीं करना चाह रहे हो तो एक रैपिड रिवीजन का वीडियो है लास्ट ईयर का, लास्ट बैच का भी एक है, वो भी अच्छा वीडियो है, यू कैन वॉच दैट. और देयर आर 2 MCQ डिस्कशन वीडियोस. वन इज FMG रिकॉल एंड वन इज एक्सपेक्टेड क्वेश्चंस बोल के. तो वो दोनों भी अगर आप कर लोगे थोड़ा 1.5x 2x में देख लेना, दैट शुड बी फाइन. Right? Ashwin, that's purely faculty discretion. Okay, that should be fine. That should be fine, Malvika. Okay, so please be consistent with your efforts. You all will do fine. Sir, how do we do ortho last time? I didn't understand. What are you saying, Darshan? If you want some, thing that if I want some fast track revision, I'll try to do that. Sir, I gave. That's a good score to be consistent with. Okay, don't worry about any random scores and stuff. Just keep doing your work. The 60% is good enough to be happy about, and you're going to improve only. These are all baseline scores that you're getting right now. It is not the reflect in radiology. You will not get this score only. Okay, it's only going to improve from here. This is the baseline score without revision, without stuff. Many of you must have spent time on pediatrics. This is a baseline score. Okay, so don't be worried. And radiology is a lot of thinking also involved, right? So thoda sa rahega waisa, but should be okay. Anatomy, okay. Sir has done, right? So let me see. Okay. 3 hour का video देखा था sir. 30 score किया है. Nice. Very happy about that. So that. Okay. So it will help you. Don't worry. Chalo. All the best, guys. I don't want to waste most of your time. And go back home. Start working for your next subject. I believe these are short subjects. ये manage हो जाएंगे. मैं भी एक YouTube revision video बनाऊंगा. वो कर लोगे आप हो जाएगा. Right? Concentrate on your major subjects right now. For these subjects, there is enough time for you to keep doing that. Okay. All the best, guys. Take care. We'll meet up again. Okay, I'll come back again in between, and we'll have a discussion. Okay. Thank you.